Well, good evening and welcome everyone. Thank you so much for joining us for another Wellness Webinar Series event with Jefferson Health. My name is Sarah Breckbill and I'll be serving as your program facilitator and will present your questions to our panel of experts. This evening, Jefferson Health spine experts will discuss chronic pain of the back or neck, non-surgical and surgical treatment options, as well as the latest research. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. If you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, with that, I want to introduce our neurosurgeons and spine surgeons for the evening, including Dr. Anthony Stefanelli, Dr. Alina Hattar, Dr. Kevin Hines, and Dr. Daniel Franco Martinez. Welcome, everyone. Thank you so much for joining us. I'm going to go ahead and give each a minute of you to just say hello, tell a little bit of background information about yourself, and then we will dive into the questions. So, Dr. Stefanelli, we'll go ahead and start with you. How are you doing this evening?
Good. Thanks for having us, Sarah. Yeah, my name's Tony Stefanelli. I'm one of the neurosurgeons here at Jefferson. I do primarily spine surgery and complex spine surgery. I did all my training at Jefferson Med School, residency, fellowship in complex spine here. So I've been here for quite some time, and I'm happy to be part of the Jefferson family for a long time now, and happy to be here.
Absolutely. Happy to have you. All right. Dr. Hattar, how are you doing?
I'm doing great. Thank you for having us, Sarah. My name is Alina Hattar, and I'm proud to be a neurosurgeon at Jefferson who specializes in spine, and very proud to be part of this incredible group. I completed my residency as well at Jefferson, and also completed a complex spine fellowship at Jefferson. After that, I completed a skull-based fellowship where I also had the privilege of participating in predominantly spine tumor surgery for patients with certain syndromes, tumor syndromes, such as neurofibromatosis. Now I'm just very happy to be taking care of spine patients here at Jefferson.
Absolutely. And we're happy to have you. Okay, great. Thank you. Okay, Dr. Hines, welcome. How are you doing?
I'm doing well. Thank you for having me. My name's Kevin. I'm one of the other neurosurgeons at Thomas Jefferson as well. I do a lot of spine surgery. I also perform procedures such as neuromodulation that can also be used to treat spinal pathology as well, or spinal pain. I did my training at Jefferson, spent a little bit of time at Mayo Clinic in Minnesota, but otherwise I've been in Philadelphia for about the last 10 years.
All right, terrific. And last but not least, Dr. Martinez, how are you doing?
Hi, good. Good evening, everyone. Yeah, my name is Daniel Franco. I'm, I guess, the last of the four spinal neurosurgeons of tonight. Similar to my other colleagues, I did all of my training at Jefferson. I've been a big family for the last close to 10 years at this point, so it's a pretty tight group, thankfully. And I'm very happy to be here and excited to hear the questions and hopefully inform our patients a little bit better.
Absolutely. I know we've received a lot of questions, so without further ado, I think we should just go ahead and dive right into it. We'll go through the submitted questions first and then turn to our live questions from the audience. So to kick us off with the first question this evening, Dr. Stefanelli, this one is for you. Can you discuss degenerative disc disease and any surgical and non-surgical options available?
Sure. Yeah, so degenerative disc disease is a very common term that's thrown around quite a bit, that patients will hear from their family doctor, from radiology reports and things like that. In and of itself, that term degenerative disc disease is actually quite interesting because it's really just a broad term to describe a type of arthritis that happens in our spine and everybody's spine as we get older, unfortunately. There's two real parts to the spine. If you think about it in a very simple way, there's think of it like bricks and mortar. So the bricks are the bones, the spinal vertebrae that everybody sort of thinks of when you picture of a spine. And the discs are the mortar or the shock absorbers that are between each vertebrae, right? So you have the hard bones and then the disc, which I describe it to patients generally, it's like gelatin wrapped in saran wrap. So there's like sort of a gelatinous core that's like a thick jello, and then wrapped around that is sort of a tough coating that holds that in. And then again, that's functions like the shock absorbers on a car to take the brunt of the movement of the spine and help with the movement of the spine. The term degenerative disc disease is just simply meaning that over time, those discs lose their water content. So they literally dehydrate and dry out over time. And that can result in the disc becoming smaller, even disintegrating completely. In and of itself, degenerative disc disease is not a problem. It's a type of arthritis that can lead to problems, but everybody will get some degree of that as they get older. Where people get problems from degenerative disc disease is if the disc causes enough arthritis to push on some of the nerve structures that are behind the disc that live in the spinal canal. So the nerves and spinal cord live right behind the discs, essentially in a canal that runs along the spine. So sometimes when those discs wear out, it can cause problems where people will develop disc bulges, where the bulge will come out backwards into the spine and to pushing on the nerve. The disc can dry out again and cause scoliosis. So people know that children get scoliosis sometimes when they're born, but there's another type of scoliosis that people get as they age called degenerative scoliosis, something that my colleagues in all treat surgically, that as the disc wear out and the joints wear out, the spine can become tilted and shifted. And the result of that is that can put pressure on some of the nerve structures as well and cause back pain and nerve pain and things like that, right? So in and of itself, treating degenerative, there's nothing really to do for degenerative disc disease in and of itself. That's just a normal part of aging that everybody will unfortunately have. And that doesn't mean that you'll be symptomatic from it. You can have degenerated discs, and that doesn't mean you'll have symptoms from it. When you have nerve compression from those things, or spinal cord compression, or scoliosis, those are conditions that are sort of a secondary result of degenerative disc disease. And those can be treated generally either from a conservative standpoint with physical therapy and injections and so forth, or if there's spinal cord compression, sometimes generally we recommend surgical intervention to free the spinal cord. So it's kind of a very broad term for a lot of different problems that people have in the spine. But I have a lot of patients that'll be like, oh, my family doctor, I read a radiology report that I have degenerative disc disease. That's just a normal part of being a human being. And if you imaged everybody in their probably late 30s and up, to their 70s, 80s, everybody's going to have some degree of that in their spine to more or less degree. So it's nothing to worry about if you have it. It's just if you become symptomatic from it, there's a lot of different ways to treat the results that come from it, if that makes sense.
Okay, thank you. And I guess, is there a specific point that you would suggest someone seeks surgical intervention? Do you mind just expanding on that a little bit?
Yeah, sure. I mean, again, the problems that it can cause are so vast, so I'll just keep it broad. But generally, when people have nerve compression and they fail conservative therapies. So, and I say nerve versus spinal cord. The spinal cord lives in the neck and the mid-back, but there's no spinal cord in the lumbar spine. It ends in everybody around the top of the lumbar spine or, the bottom of the thoracic spine. And then it frays off into a bunch of little, what we call nerve rootlets. They're just, they're the bottom part of the spinal cord. You could think of it like that. They function in very different ways. So even though it's all connected, pressure on the spinal cord is generally something that we recommend treatment for, because spinal cord compression causes, when people become symptomatic from it, it generally causes permanent loss of function, and it's usually painless. And it's a progressive disorder. It's not something that generally happens overnight unless somebody's in a bad car accident or something like that. That we generally recommend when people have symptoms from spinal cord compression. We recommend surgical intervention to remove the pressure off the spinal cord first. When it comes to the low back, which is what a lot of people seek surgeons and pain doctors for, because spinal cord compression is generally painless. Spinal nerve compression, which happens in the lumbar spine, is painful. So people can have problems with standing and walking. People can have what we call radiculopathy. A lot of patients will hear the term sciatica, shooting pain down the legs. Generally, those things are not an emergency, and we tend to tell patients to treat them conservatively with things like physical therapy, chiropractor, injections, and do the conservative things first, because the reality is most patients will get better without surgery. For the patients that essentially fail those more conservative therapies, then I tell patients, then we start talking about surgery as sort of the next step in the treatment modality after you've failed the conservative therapies. But I generally tell patients in non-urgent situations, which almost never happen in the lumbar spine, that surgery should be the last step. I should be the last person you've seen. And it's not to torture patients or withhold care. It's because generally patients will get better without undergoing, potentially a large surgical procedure.
Okay. And I think that's promising to hear for many people listening. So thank you. All right. Next question here. Dr. Hattar, are there any procedures out there for severe spinal stenosis and osteoporosis?
Certainly, I think that's a very important question, and I would like to kind of answer it in two parts. So for the question of spinal stenosis, I think a theme here should be that there's really no cookie cutter answer that works for everyone. We certainly critically evaluate imaging findings, but we really try to contextualize that within the patient's experience, what they've been feeling, their symptoms, and what, like Dr. Stefanelli said before, they've tried before. Especially for pathologies that of the lumbar spine, as well as certain other pathologies, a lot of these symptoms are not necessarily emergencies, but that being said, they can certainly affect quality of life for patients. As far as stenosis, spinal stenosis, depending on the region of the spine and the pathologies involved, basically decompression surgery can be done from different approaches and different ways. For example, they can involve a simple laminectomy of the lumbar spine, or they can be combined with fusion, for example, if patients have certain symptoms and imaging findings that are present, essentially. So it's really a complex question, and I guess spinal stenosis exists in many contexts, and so it's hard to kind of give you one surgical procedure that can be done for that. But certainly, we all evaluate patients for different procedures and kind of give them the best option that will hopefully provide them with the most relief and hopefully prevent their symptoms from getting worse. As far as osteoporosis, that's a very important consideration for patients. It's very relevant in the context of spine surgery. So osteoporosis is really a severe form of bone loss or bone mineral density loss. Essentially, it's measured using a bone density scan, and we check something called a T-score, which represents essentially the difference between the bone quality of a healthy adult compared to our own bone quality for whichever patient is getting the scan. And basically, osteoporosis is present when that T-score is less than -2.5. And a lesser form of osteoporosis called osteopenia is present when that T-score is between -1 and -2.5. So it really tells us how strong the bone is. And as you can imagine, I mean, Dr. Stefanelli made this great analogy that our spine is composed of, bricks and mortar. And definitely if the bricks are very weak and fragile, it becomes just very hard for those to accept instrumentation and be fused. And so it becomes very important to optimize patients for surgery if they have especially severe forms of osteoporosis. Oftentimes we send patients to colleagues such as endocrinologists and rheumatologists to put them on anabolic medications such as Forteo or Tymlos. They're injectable medications that are kind of proven to reverse some of those bone findings in osteoporosis. And so it becomes important to kind of optimize the patient if we think they might benefit from spine surgery before doing surgery if they have that diagnosis.
Okay, great. Well, thank you. And a quick follow-up there, is there any age limit to any procedures?
Again, I think every case and every patient is unique, and it's very hard to give a cookie cutter answer, one size fits all answer that we go with. It really depends on patient symptoms, their imaging findings, and whether we feel like surgery, the benefits outweigh the risks for surgery. And we have an open discussion with patients and their families about all of that and what can be expected from surgery and what we hope would be the result of surgery. So I think as long as we are all honest about, what can be expected, and that there are unfortunately risks with any surgical procedure, but if we think the benefits would outweigh the risks and there's a tangible, hopeful improvement with their quality of life, then I don't think there should be an age limit for patients. I mean, that being said, we all know that when patients are more medically complex, they have a higher risk profile. But that's why it's important for us to weigh the risks and benefits and see if somebody could benefit from what we do.
Okay, thank you. All right, moving along here, Dr. Hines, question for you. Is physical therapy the only modality available to manage chronic pain in your back and neck?
There are a lot of ways to help with pain in the back of the neck. I would say physical therapy is very important. It helps strengthen your core and your back musculature. I like to tell patients that your spine is a little bit like a flagpole, and the musculature in your core and your back are the tethers that hold that flagpole and protect it from gusts of wind or other forces, and help encourage and solidify your long-term spine health. So while it's certainly not the only modality, it is a very important one that whether you are doing it just physical therapy, combining it with other things like acupuncture, chiropractor, aquatherapy, medications, nerve pain medications, injections, ablations of nerves. Those are all other things that can be added to that. Physical therapy still plays a foundational role in improving the health long term of your spine, and even included in surgical therapy as well, preoperatively and postoperatively. It's very important for recovery. So, in addition to physical therapy, like those things I mentioned, and then, eventually things like surgery, whether it's spinal decompression or fusion or stimulation, are all options to treat. And similar to, what Dr. Hattar had mentioned, is that it is very tailored to the patients themselves. We try to understand the type of pain that they have. We try to combine their clinical symptoms with their imaging to find the best option to try to help their pain. And, sometimes that's physical therapy and injections, and sometimes there's something that's unstable that would require fusion or be recommended for fusion. And it's really about trying to tailor the treatment to best improve quality of life in patients with spine disease.
Absolutely. Okay, thank you. Dr. Martinez, to build off of that, I know Dr. Hines mentioned chiropractic intervention or acupuncture. I'm just curious for your thoughts on those options.
Yeah, I mean, they certainly work. I think in general, we try to do everything, even though we're surgeons, we try to do everything possible to prevent an unnecessary surgery. And so, chiropractors and acupuncturists certainly have a role in terms of treating chronic pain. In terms of chiropractor, for thoracic and lumbar spine pain, I think that they can be really effective. They have various techniques that can certainly help with the current pain situation that a patient might have. In terms of neck pain specifically, I'm generally a little bit more hesitant, just because there's certain manipulations that chiropractors might do for the necks that might be a little bit on the aggressive side, and certainly the risks of having a new injury from neck manipulations, I think, in some cases may outweigh the possible benefits. And so, not to say that chiropractor for neck pain is not something that could be effective, but it certainly has to be done by someone that's experienced and I suppose with delicate hands. And in terms of acupuncture, although it can be a bit of a hit or miss, but when it works wonders. And so in acupuncture, its side effects are pretty minimal, pretty much nothing. And so, when you're working your way up into having a uh, a potentially invasive procedure, you certainly want to check as many boxes before going through that. And so, certainly acupuncture and chiropractors are part of that paradigm.
Okay, great. Thank you. Okay, Dr. Stefanelli, let's go back to you for a minute. I know you mentioned sciatica earlier in our conversation. Are there any cures for sciatica?
Yeah, no, that's a great question. Yeah, there's many cures for sciatica. Interestingly, and I tell almost all my patients this, um, almost everybody in their lifetime will get what people refer to as sciatica. Right now, that's kind of a misnomer. We call it radiculopathy is the real term for it, but sciatica is actually a nerve that's in the leg. It's not in the back. And sciatica, what people know as sciatica, is actually compression in the spine, not in the leg. But more importantly, I tell my patients almost 90% of sciatica will resolve. So when people have an acute flare-up of radiculopathy, leg pain or arm pain, it can happen in any level of the spine. Um, Almost 90% of that will resolve, even if you did nothing, right? So I generally tell patients within like 6 to 8 weeks. Sometimes I wait a little longer if the patients are younger, but essentially within 6 to 8 weeks after the flare up, if you will, of leg or arm pain, even if you did absolutely nothing, you literally just went to work, you got through the pain, you took some pain meds, almost 90% of that will resolve with no intervention. So that's the good news. Now we operate on a lot of patients with sciatica because a lot of people get sciatica. So even though only maybe roughly 10% of people will go on to need will not heal with conservative therapies, that 10% makes up a large group of people because there's a lot of people that, like I said, most people will get this at some point in their lifetime. So generally, yes, most people will heal on their own without the cure for it is just the tincture of time, right? Like time will heal sciatica in most patients. For the patients that don't heal on their own, there's a couple of things we can try, and we've alluded to some of them already. So we have things like, we talk about the conservative things like physical therapy, acupuncture, PT, all these sorts of things. They do help. They do work. They're not mumbo jumbo. Like physical therapy cures people of sciatica. That's very true, and it avoids many patients getting surgery. And then, the next step after you fail those sorts of things, we talk about surgical intervention. And for sciatica or leg or arm pain, surgical intervention is generally extraordinarily effective in treating those. And again, that can mean something as simple as a same-day minimally invasive microdiscectomy in the lumbar spine, meaning we make a tiny little incision like this. We put a tube down. We get, like a metal tube right over the disc. We drill out a little tiny piece of bone. We move the nerve over to the side and we pluck the disc fragment out, the little part of the disc that is herniated against the nerve. The procedure takes about a half hour, 45 minutes, and patients will go home the same day. But in the neck, it can mean something different. Generally, in the neck, it can mean a fusion procedure. It can mean something called a disc replacement. So I won't go too much into that because there's a lot, every specific situation of how it's treated is very, very vastly different. But generally, to sum it up, time will fix it most of the time. If time doesn't work, conservative things like injections from pain management and physical therapy will help the symptoms alleviate. And if that fails, then we talk about surgical intervention. But most people will not need surgery for sciatica or radiculopathy.
All right. Very helpful. Thank you. Okay, Dr. Hattar, we will turn to you now. Talking a little bit about pain. So what options are there for pain management and how can someone improve their quality of life?
Perfect. I think my wonderful colleagues already touched upon a lot of these options. Basically, there's pharmacologic management with medications. There's physical therapy, especially, we want to be able to strengthen our backs and hopefully take some, pressure or load off of the spine with that. Interventional pain management, such as epidural injections or ablations. There are neuromodulation procedures that I'm sure Dr. Hines can go into much more detail than I could. about chiropractic manipulation, as we mentioned before, massage therapy, acupuncture, basically everything, short of surgery. And then once those are exhausted, that's when we really consider surgical management. As far as improving quality of life, I think that's a personal question for each patient. But I would say the biggest thing is to try to stay medically healthy, staying active, participating in physical therapy if you're having an acute or ongoing spine issue, tending to any medical issues like diabetes or, for example, pursuing weight loss options when appropriate. Beyond that, I think, sometimes surgery is part of that equation for patients who have exhausted everything else and may have, for example, neurogenic claudication or severe pain in the legs and from lumbar stenosis and can't walk very far. Then surgical intervention hopefully provides them with some relief, and we hope would be a solution for improved, quality of life and functionality.
Okay, thank you. All right. Sort of as a follow-up to that, I'll turn to you, Dr. Hines. So we've talked a lot about different treatment options. Can you just talk through a little bit more of the less invasive surgeries for back and neck pain?
Sure. I think less invasive, minimally invasive, these are all terms that people throw out to discuss surgical options. And there's nothing that necessarily meets strict criteria to be defined as minimally invasive versus maximally invasive. I think that it's a philosophy of trying to do the least amount of surgery to accomplish the biggest improvement in quality of life. So can you decompress the nerve without having to do a big open incision? And some people do different types of approaches. So, for example, a lower back lumbar region, something that may be constitute a minimally invasive option could be tubular approach. So instead of doing a midline incision and dissecting the muscles off of the midline to get out to some of the lateral elements to shave down bone and decompress the nerve, some people go off the midline and go either through a small incision or through a tube that will limit the size and the extent of muscle dissection and incision. So that's some ways that people can define things as minimally invasive, whether they use a tube or a special retractor to avoid disrupting a lot of the soft tissue. You can use an endoscope in some scenarios to allow you to approach the nerve without having to dissect all through the back. It's more almost from the back and the side. There's also when you're trying to, even if you do a fusion, you can come from the side of the spine with a smaller incision, less dissection to put a big graft and take out the disc and still do it without having to take off a bunch of joints and bone from the back. So, minimally invasive in itself is not a strict term. I think it's a matter of finding, specifically tailoring the needs of a surgery to the patient in a way that is least disruptive to their soft tissues and bone. And then, the least invasive surgery of all is no surgery. So I think everyone on the panel here will do their best. If there's something that will, just like Dr. Stefanelli mentioned earlier, if there's something that would resolve on its own, well, that's what our goal is we'd rather do no surgery if we think that that's an option for you. Ultimately, most of these things are a quality of life issue. And if the conservative therapies are giving you the improvement in quality of life that you want. But, just to kind of summarize, as far as minimally invasive options, you have things like different approaches from the side. You can do things through a tube or through a special retractor. You can do what we call a hemilaminotomy, where you approach from only half of the spine and using an endoscope. And then, like Dr. Hittar mentioned, there are things like neuromodulation and stimulation, where if someone doesn't want to undergo a large deformity surgery and they have mostly back pain, sometimes things like stimulation might be an alternative for someone who's either not very healthy or very advanced in age and would not want to undergo a large correction. So those are just an intro to some of the minimally invasive options that are out there as well. And then the other thing to consider is motion preservation versus not. Can you decompress a nerve without having to fuse the segments? That's important to people. So a lot of people ask about things like, foraminotomy or a laminotomy versus a disc arthroplasty, which is still taking out a disc but putting in a replacement that has motion. And then there's, say, a fusion where you take out the disc and put a graft in that has no motion for the segments to fuse together. So these, are all tools that we have in our arsenal to try to combat degenerative disease. And not everyone is a good fit for a minimally invasive or a motion preservation option. Sometimes there's reasons, like people have instability, and we don't think it's good that the motion is still there because it would cause a problem to recur. So that, once again, these are all case by case, patient by patient specific tools that we do to try to ensure the best outcome.
Okay. All right. Thank you. Okay, before we go to the next question, just a quick reminder, feel free to drop your questions in the chat as they pop up. We'll be turning to live questions in just a minute or two, but for now, I want to turn to Dr. Martinez. If you could talk through any new treatments or research that's being done for chronic back pain, as well as maybe any research being done for spinal cord injuries. Interested to hear the latest.
Yeah, sure. So, first we have to separate those two because they are obviously vastly different conditions. And so, starting with back pain, chronic back pain affects millions globally. It has a profound impact on quality of life, productivity, emotional well-being, loss of days of work. That's one of the principal causes for Americans to, miss work days. So it's certainly a problem that affects a big majority of patients. So, like Dr. Hines was saying, we were talking about, less invasive type surgeries. Over the last decade, there's been advances in what's, quote unquote, minimally invasive spine with like new techniques that have, transformed how we approach chronic back pain and structural issues like herniated disc or stenosis. Procedures such as endoscopic spine surgery, which has gotten a lot of traction in the last few years, which it now allows us to operate through a incision that might be less than a centimeter in some cases. Which is considered basically the follow-up evolution to what more quote unquote traditional minimally invasive spine surgery like tubular surgery is concerned to. So this new approach minimizes tissue disruption even further, reduces postoperative pain, and significantly shorter recovery times. And then also touching on the neuromodulation thing, spinal cord stimulation, it's continuously advancing. There's new implants that come to market relatively frequently. There's changes in the stimulation parameters that can allow you to get better results and different outcomes on a patient-to-patient basis. And with the advent of artificial intelligence, there's new interpretation algorithms that can kind of adapt to the different pain syndromes that people have and make the stimulation a lot more effective than it used to be. In addition to this, there's been a lot of innovation in the medicine side of things as well, outside of surgery and procedures in general, like medicines that are, not necessarily opioids, which as we know have been unfortunately abused for a long time, and now the patients are paying the price of it. And so there's new medicines that are coming out that and are being studied that for their ability to target pain pathways directly, and trying to offer some relief without the associated risks of opioids. So that's also an exciting area. And then lastly, we've now recognized that chronic back pain isn't just a physical issue. It's deeply intertwined with psychological and emotional factors as well. And so different new psychological and lifestyle interventions have come to be a big part in the treatment of chronic back pain, and have certainly changed how we think through these problems. So that's a little bit of a summary in terms of what's going on with the treatment of low back pain. Low back pain is a very broad term. It's really hard to discern and dissect exactly what we call the pain generator is, and it could be different for everyone. And so I think it's important to sit down and look at it on a case by case basis and try to really hone down on what could be the possible pain generator for one patient or the other, and then based on that, kind of get a treatment plan. Now, switching gears a little bit to spinal cord injury. Spinal cord injury is one of the most devastating injuries that someone can get. It very often leaves individuals with significant challenges, paralysis, being completely dependent on family or caretakers, or certainly something that causes a huge burden to patients that has suffered these very traumatic injuries. And just to set the stage a little bit, it's important to understand that the traditional treatment for spinal cord injuries has focused primarily on stabilizing the spine, preventing further damage, and maximizing recovery through rehab, physical therapy, and also decompression, whether it's in your cervical spine, your mid back, or whatever it is. You kind of take the pressure off was caused by this traumatic event, and then kind of allow the body to just heal itself. And so traditionally there's a very limited effective intervention that we can do outside of decompressing the spinal cord, relieving the pressure, and fusing the air to allow for no motion, and give the chance for the body for the best recovery possible. But nowadays there's talks about regenerative medicines, particularly the use of stem cells. This is all experimental still. There's no trials yet that have shown a clinically significant difference in terms of outcomes, but certainly that's where things are moving towards. We're still, I would imagine, a few years away from having something that's implemented and actually approved, say, by the FDA and that kind of stuff. But that's something that's really exciting in the field of spinal cord injury. And then same coming back to the neurostimulation devices. These devices are very versatile. You can use them also to potentially bypass the area where the spinal cord injury happened and allow for potential recovery of motor function below the level of the injury, which is also really exciting. That's also more or less in the experimental stages, but it's also very promising. While again, the progress that we've made over the last few years is promising. And I forgot to mention, like Jefferson, at least the Center City site is a regional spinal cord injury center, which only in the East Coast there's only a few of them, I believe, less than 5. And so we are the center that sees a lot of these spinal cord injuries, for better or for worse. But that just means we have a lot of experience compared to other nearby centers. And just to kind of finish up, the progress is promising, but the spinal cord is a very complex structure, and the variability of the injury types makes it very difficult to find a cookie cutter or a one size fits all solution. And so it's still going to be a little bit, a little while before we make a huge advancement in it, but it's coming.
Yeah, and nevertheless, still really exciting to hear some of these updates. So
yeah.
thank you. Okay. All right, Dr. Stefanelli, we will turn to you now. Question for you here. What causes spinal arthritis and what treatments are there?
Yeah, Sarah, that's a great question. That we all get that every day in clinic. I tell patients, there's a really simple answer. Just getting old. And I don't mean old, like I tell patients, like even in your late 20s and starting then really, all the way up into, 60s, 70s, 80s, whatever, our spines will degenerate over time. Some patients can have a much more greater degree of that, and some patients have a lesser degree of that. And some of it depends on extraneous factors, like your 40-year construction worker who spent his whole life lifting up 200-pound things is probably going to have a worse, lumbar spine than your, 30-year-old ballerina, right? Like there are some external factors to consider. But the reality is a lot of it is actually genetic as well. So these types of arthritis problems that people get are just sometimes, sort of hardwired into our DNA, right? That's the reality of it. So, it's a component of bad luck. There's a little bit of component of lifestyle into it, but a lot of it is just normal human aging, that the way our bodies, we're biped, we stand on our legs, right? We're one of the few mammals that does that, or only, I guess. But uh, as a result of that, we put all of our axial loading forces, all of our body's weight onto our back, right? Like we're loading all the forces onto our lumbar spine. And, as a result of that, that puts a lot of, and we're big animals. Human beings are large animals. So you can imagine that's a lot of forces that your lumbar spine has to deal with over the course of the human lifetime, which is, 80 plus years. So all these things combined are kind of a not friendly way of saying it's just the way we are. So, the things I tell patients, what can you do? Everybody asks, like, what can I do to stop it? Really, there's not much you can do to stop it. I mean, it's just whether or not you become symptomatic from it is what you deal with. But the things you can do are the things we've been talking about, just generally speaking, to help reduce the risk of you needing or having problems in the future. Simple things, good diet, keeping good core strength, exercising, good, all these simple things that everybody talks about are really helpful. I mean, core strength in general, people say like core strength, you have a set of muscles that wrap around your spine that really hold our posture together. And the spine only does half of the job. It's all the big, heavy, huge muscles that live deep inside the body, running along the spine that hold us up. Keeping those muscles strong, just like Dr. Hines said, right? Like you have a support structure. And it needs support, the flagpole analogy that he made. You have to keep the pole strong. So keeping those muscles strong and powerful will help keep the spine healthier as you age. But even the healthiest people, I mean, we all operate. I operate on athletes all the time, and people that are like marathon runners. It's just some of it is like these people are at their peak level of fitness and they get spine problems too. So some of it is just the way we're built and the way genetics happened for us. But just keeping yourself healthy, keeping good exercise, core strength will probably cause some reduction in the chances of you having problems in the future.
Okay. Thank you. All right. And we're just about to dive into the live questions, but Dr. Hattar, as Dr. Stefanelli just mentioned, with prevention, is there anything else you'd like to add on there? How someone can prevent back and neck issues? Anything that we can do to keep our necks and backs healthy other than
I
what
think,
just Stefanelli said?
yeah, Dr. Stefanelli did a great job describing everything. I mean, for me, I would say maintaining a good posture is really important. Whether you spend long periods of time at your, at a desk or do something more physical, it's important to maintain a good alignment, and back strengthening and core strengthening is definitely part of the solution. Staying medically healthy, avoiding tobacco products and smoking can help keep bones healthy. And I just wanted to, again, as Dr. Stefanelli said, I just wanted to reinforce that just because somebody has a spine issue doesn't necessarily mean that they failed at those things. These are just, different options to keep our spines as healthy as possible. But at the same time, unfortunately, there's things that are hard to change or we cannot change, like genetics and things like that are also at play. And just normal aging, as we age, we expect to get arthritis and things like that. So all of those are kind of normal changes that happen to people. So, just because you have neck or back problems doesn't mean that you didn't do something properly. But that being said, all those things will keep you as healthy as possible with respect to your spine health.
Absolutely. Okay. I find myself wanting to sit up straighter now. Thank you. Okay. So with that, let's go ahead and dive into our live questions. We've been receiving a ton, so thank you. I'll just go ahead and read through these questions, and feel free to, whoever wants to chime in, feel free. I'll direct them, but others feel free to chime in. It can be a conversation. So for this first question here, Dr. Hines, I will direct this to you. What does a spinal cord stimulator do, and is it recommended instead of spine surgery?
So a spinal cord stimulator essentially is wires oftentimes placed through needles that sit on the back of the spine outside the covering of the spine called the dura, and transmit electrical signal to the spinal cord to interfere with chronic pain signal that reaches the brain from nerves damaged from causing chronic pain down below. So it oftentimes can provide in carefully selected patients a meaningful decrease in pain. However, it does not necessarily get rid of a problem if there is something there. So, for instance, if there's a disc that's actively pushing on a nerve, that's not necessarily a good replacement for spine surgery, as you know, a joint or a disc or a ligament that's pushing on the nerves is likely to continue to aggravate those nerves and make the pain worse over time. So it's an option for, I think we see it commonly in patients who don't have things that are actively pushing on the nerves on their scans, but they have nerve pain related to specific nerves. Or patients who previously had a long history of arthritis and had a decompression, and a lot of their pain got better, but they still have bad chronic nerve pain, despite the nerves being freed up now. So those are a couple examples of people who might benefit from spinal cord stimulation, to help try to block that signal and improve quality of life.
Okay, thank you. All right, next question here, Dr. Hattar, this one I'll direct for you. What is a good treatment for pain from severe scoliosis?
So again, it's kind of a complicated question. I think it really depends on the patient's symptoms and whether we think that their pain is coming from their deformity itself or from maybe a nerve root or something else that is being pressed upon. If we think that patients can benefit from even minimally invasive or a smaller surgery, we oftentimes start with that. There are obviously larger, more complex deformity surgeries that can be done. If we think those are indicated, that unfortunately has a different risk profile and different recovery for patients. But we oftentimes, just like with, medical management or conservative management, we oftentimes start with something smaller and proceed with bigger surgeries for patients where we think, they may benefit from a bigger surgery. It's hard to kind of answer that specific question. And it really depends on your degree of scoliosis and all of that. So, it's kind of complicated for each patient and a different situation that we analyze separately for each patient.
Absolutely. Definitely a case-by-case basis, but thank you for taking a stab at it. Okay, next question here. Whoever wants to chime in, feel free. This person is just wondering, what doctor should you see after your primary to assess multiple back issues? So upper back arthritis, compressed lower disc, hip and pain all the way down to the leg.
Yeah, I can answer this one, Sarah. So I think that's a great question. I think the best people to seek after you've talked to your primary care doc, because I think your primary care doc is a good first start because they know generally the basics of spine management and simple sciatica and things like that. And they can probably get you through it without the need of doing anything further. But after that sort of the very basics have been exhausted, I think the right person to see is a surgeon, and that doesn't necessarily, like a neurosurgeon, one of us, any neurosurgeon, right? Because who specializes in spine in particular. And that doesn't mean that, Dr. Hines said this, we've all said this. That doesn't mean that we're going to offer you surgery, but oftentimes, we as neurosurgeons, not just us, are the experts in spine, right? So that doesn't necessarily mean that we're going to say, hey, you're a spine, we want to do surgery, we're going to jump to surgery. But we know how to get patients plugged in with the right treatment modalities for them, when oftentimes patients will feel lost because they know they can go to their primary, they can see a pain doctor, they can see a physiatrist, which is like a rehab doctor. And oftentimes all of us will send patients to an amalgamation of those collection of people, right? Pain docs, physical therapists, et cetera. But our role as the neurosurgeons, the spine surgeons, is very unique in that we are we know how to get patients to where they need to be because we're sort of the end stop for spine problems. So we know, hey, you don't need surgery now, but you may in the future, but let's try these 10 things and let me get you plugged in with a pain doctor, or let me make you a referral to physical therapy or this and that. So I think, we're always happy to see patients, even when they don't want surgery and they have back problems, because we can at least say, hey, yeah, you might not want surgery, but let us help you get plugged in. We can at least get you a good treatment algorithm of how to get your pain resolved and give you good options of getting you plugged in with the people that can get that sorted out for you.
Okay, thank you. All right, next question here. Whoever wants to chime in, feel free. As far as the decompression surgery, would age play a factor as to whether it's recommended? And if someone is in their 90s, what might be some recommendations?
I can answer this one. So yes, so the short of answer is yes. Age certainly plays a factor, but not age in and of itself. Is really the older you get, you tend to have more comorbidities, more medical issues going on. So there is not a set age where surgery becomes impossible. You know, even though it's few and far between, we have operated on 90+ year olds in the right situation. Surgery can still be helpful. However, again, we typically like to avoid surgery as much as possible and make sure that we've tried every single option available to us that may be able to treat the condition perhaps effectively. And um, if you get to a point where you've tried everything um, and nothing has worked, and you know you certainly have um, your quality of life is affected, and we have a chance of improving that, and then certainly it can be done. But you know the right precautions have to be taken.
Okay, thank you. All right, next question here. What constitutes an effective treatment regimen for lumbar bulging sciatica?
I can take that one. I think that's an interesting question because the lumbar bulging sciatica is a broad term. It can mean a lot of things. Going back to what Dr. Stefanelli said about degenerative disc disease, it could be on a spectrum of discs that are very dried out and pushing on nerves, or discs that are just starting to bulge and not necessarily pushing on anything. So this once again certainly requires a personalized, targeted type of evaluation. If those bulging discs are not pushing on nerves specifically, oftentimes core strengthening, physical therapy, and injections are things that we think about as being effective with low risk. If that bulge is compromising the spinal canal and the nerves are unable to pass through to where they need to go in the legs, then that could become an issue where we would talk about, either hoping it resolves with time, which sometimes the body will use inflammation to eat up a bulging disc, or if it doesn't, or if the bones start to slip, then we have to talk about potentially decompressing those nerves. So it all does depend a little bit about what the specific lumbar bulging sciatica is and where that pain is coming from and what does that correlate to on the imaging.
Okay. All right. Thank you. And I'll just do one more live question here, and then we can wrap up for the evening. But Dr. Hattar, a question for you here, and if this is a little specific, let us know. But this person is wondering, can Prolia injections be helpful for back or neck pain?
Um, I mean, they're helpful in terms of, I guess it depends on what kind of back or neck pain you're having. In most cases, these injections are helpful in strengthening bone quality. And so, I think I wouldn't rely on those exactly to necessarily alleviate most types of neck or back pain. But certainly, like Dr. Steph, like the whole group has been saying, there are a lot of other options, and even time can sometimes help, alleviate certain flare-ups that patients have. And so, it can definitely be part of the treatment kind of equation, and especially it's important for patients who may need surgery in the future. But I think more than anything, it's kind of targeting more just bone quality, and I think indirectly, yes, it can help avoid things like osteoporotic fractures, which can be quite painful. So in that sense, I think it can help with quality of life for patients as well.
Okay. All right. Well, thank you. And with that, I have one final question for this evening. And my question would be, what are your goals for everyone listening in on this webinar? So what do you want to make sure that our viewers take away from tonight? So Dr. Stefanelli, I'll go ahead and start with you.
Sure. Yeah, I mean, I think one thing I really would hope, any patients in general would take away from this conversation or any conversation with a spine doctor or spine surgeon is that really two things. I think number one, seeking the opinion of a surgeon early, and not that you want surgery or should even get surgery, but like I said, I mean, we're the end gap, we're the final stop in that pathway, and we can help direct people that oftentimes will feel lost in the 10 different places they have to go. So that what I was alluding to earlier is, um, we can put people in the right direction. Now, with that being said, I think going to a reputable person also is important because there are some spine surgeons that are, better than others, and certainly just simple reviews, looking at how people are on the internet is a good, it's a good way of figuring that out. But generally going to a reputable person is a good thing, and getting you put in the right direction. So to avoid maybe longer term problems that could have been solved easily with the right pathway. And I always tell patients one thing I think is very important, that I would even do as a neurosurgeon if I had a spine problem, or when I get a spine problem in the future, is don't be afraid to get second opinions and see multiple surgeons and multiple doctors, because spine is very complex, and a lot of it is just how people view things and train, and are some are more aggressive and less aggressive. And you as a patient, I think, should feel empowered to feel comfortable with your surgeon, and no good surgeon will ever take it as a bad thing. I tell all my patients, like, you should absolutely get it. You're not going to hurt my feelings. I encourage everybody to get a second opinion when it comes, certainly, to making a surgical decision about your spine. So I think those are probably two takeaways that I would hope most patients would kind of do more.
Absolutely. Being your own best self advocate. So thank you. Okay, Dr. Hattar, any closing remarks?
I totally agree with what Dr. Stefanelli was saying. I think one big thing is just that really there is no, perfect solution for everyone. Every single patient, every single story, we kind of evaluate, you know, uh, on a case by case basis, and it really becomes a conversation between, you, the patient, and the doctor, and just honesty. And we just want to help you make the best decision for your health. As Dr. Stefanelli said, we're not offended if you seek other opinions. We work in we're lucky enough to have highly regarded other specialists who work with us, so we can send patients to pain management specialists, rheumatologists, endocrinologists, physiatrists, neurologists, and we have access to that. So, we can be your guide and hopefully help you and empower you to make the best decisions about your spine that can be made.
Absolutely. Okay, thank you. All right, Dr. Hines.
I would just echo a little bit of what Dr. Stefanelli and Dr. Hattar said, but talking to a spine surgeon does not mean you're getting surgery. I think all of us agree that if we can avoid you going through surgery and there's an option that's not surgical, we would always, if we can help solve your problem that way, we'd be happy to. You know, I think spine surgery and working with spinal problems is a challenging conversation because it is all about quality of life. To some degree, you determine when you get surgery, when your symptoms are bad enough that you're not able to live the quality of life that you want, even with conservative therapy. So us talking to a spine surgeon is giving them a chance to get to know you and what your priorities are and what your symptoms are that are most bothersome. And that's a very important part of tailoring surgery or non-surgical options for patients that we think could best help them. So I think it's a conversation about your priorities and when what you want for your quality of life when you talk about your spine health and possible spine surgery.
Absolutely. Okay, thank you. And finally, Dr. Martinez.
Yeah, I mean, I think the biggest takeaway from this webinar tonight should be that we're only a small part of a large multidisciplinary team with vast experience with everything spine related. And it would be our pleasure to help you navigate what is an otherwise very complex and nuanced issue. And whether the solution, involves surgery or not, like Dr. Hines was saying, we're available to help. And I think this has been great, and we're very happy that we were able to listen to our patients and try to answer some of their concerns.
Absolutely. All right. Well, thank you so much. Thank you, Dr. Stefanelli, Dr. Hines, Dr. Martinez, and Dr. Hattar for your time this evening. I know a ton of great information was shared, and a big shout out to the audience for attending and submitting such great questions. I know I learned a ton. We will be posting an event survey so you can let us know your thoughts. Any other specialties you would like to hear from? If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please go ahead and fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars, just like this one and more. You can also visit jeffersonhealth.org/livingwell for more health content, patient stories, research, and innovation. Be sure to visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from robotic surgery to hearing loss to men's and women's health topics and previous webinars discussing back and neck pain. A recording of this event will be sent to you so you can rewatch at your convenience. And if there's anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Have a wonderful night. Thank you.